Hey guys, welcome to the MRCS Hacks. My name is Aniket and today's topic is the coagulation cascade. Now, this is a topic that has a lot of noise around it and you'll see multiple diagrams and videos online. What I hope to do in this video is to collate all that knowledge relevant for the MRCS, including the different aspects of the coagulation cascade, the things that affect it, the diseases and the investigations. Okay, so let's get started. So there are three main pathways in the coagulation cascade: the extrinsic, the intrinsic, which both go on to activate the common pathway, then goes on through a series of reactions to form a stable clot. Let's go through the extrinsic first. So the extrinsic pathway is a lot shorter than the intrinsic pathway. It involves only two factors, hence it's the main pathway of coagulation. It's activated through tissue factor being exposed to blood. Tissue factor is anything that is not found within the lumen of the blood vessel. So if there is a break in the blood vessel and the blood is exposed to tissue factor, it will set off a series of chain of events which can cause the activation of the extrinsic pathway. The first step is tissue factor being activated, which is also known as factor 3. Activated factor 3 activates factor 7, and this goes on to activate factor 10. Now, factor 10 is the most important factor in the whole of the coagulation cascade. It's also the number for Lionel Messi, and I remember it as though all the play to score a goal goes through Lionel Messi, and factor 10 is what's needed to be activated in order for the clot to form. Okay. The intrinsic pathway, on the other hand, is activated when there is endothelial injury. So the inner luminal layer of the blood vessel, when there is a break within that, the subendothelial cells are exposed, and that sets off a chain of events which causes factors to be activated and activate the intrinsic pathway. So when there is endothelial injury, factor 12 becomes activated. This goes on to activate factor 9, which goes on to activate factor 8. And factor 8 then goes on to activate factor 10. From here onwards, the common pathway takes over, and the common pathway is where factor 10, along with cofactors of factor 5 and calcium, form something called the prothrombin complex. This is formed by factor 10 plus factor 5 and calcium along with prothrombin. This is also known as factor 2. The prothrombinase complex forms and creates thrombin. Thrombin goes on to convert fibrinogen, which is also known as factor 1, to fibrin. This is really important because fibrinogen is soluble in the blood, and when thrombin acts on it and converts it to fibrin, which is an insoluble substance, it starts the formation of the clot. Now, fibrin in itself is not inherently stable, and it needs to react with factor 13 to form a stable clot. But after that point, the stable clot has formed. Now, in normal physiological circumstances, once the clot has formed and the healing process is underway, the clot eventually needs to break down. And this is done by the process of plasminogen converting to plasmin, which then acts on the clot to break it down. Okay, and I think that covers the coagulation cascade. So let's recap. The extrinsic pathway is the main pathway. It is activated by tissue factor, which is released when blood is exposed to anything that's not in the blood. It goes on to activate factor 7, which then goes on to activate factor 10. In the intrinsic pathway, you need to have endothelial injury, and when there's exposure of blood to subendothelial cells, it activates factor 12, which goes on to activate factor 9, and then activate factor 8, which goes on to activate factor 10. Factor 10 then starts the process of the common pathway. It, along with factor 5 and calcium, goes to form a prothrombinase complex with prothrombin, which is also known as factor 2. It forms thrombin, which then converts fibrinogen, which is soluble, to fibrin, which is insoluble, and fibrin is stabilized to form a stable clot by the addition of factor 13. Okay? The stable clot is broken down when plasminogen is converted to plasmin, and plasmin acts on this clot to break it down. Now, let's go through a few things that affect the coagulation cascade. These are diseases, drugs, and the investigations that can test the coagulation cascade. We'll go in order. So the first is von Willebrand disease. So von Willebrand disease is where von Willebrand factor doesn't work properly. And what this factor does is that it stabilizes factor 8. So 1 Willebrand factor stabilizes factor 8. So when it's unable to do this, factor 8 can't work properly, it can't form the platelet plug, it can't activate factor 10, and therefore von Willebrand disease is a bleeding disorder. So the next thing is protein CNS deficiency. Protein CNS inhibit factor 8 and 5. In protein CNS deficiency, you can't inhibit factor 8 and 5, and the coagulation cascade continues as normal. And this is normally a physiological process that controls the cascade. So when it's deficient, this is a prothrombotic disorder and can cause excess clots to form. Okay. The next is warfarin. Warfarin is a drug that thins the blood and is given to patients for many conditions such as AF and metallic heart valves. It inhibits factor 10, 9, 7, and 2. Okay, so warfarin inhibits factor 10, factor 9, factor 7, and factor 2. Warfarin is tested by INR, and when you standardize INRs across a population, you can form a test called prothrombin time. And since warfarin affects factor 7, it's the main way that you can measure the functioning of the extrinsic pathway. Okay, so you can measure the extrinsic pathway by measuring PT. The intrinsic pathway, however, is mostly affected by heparin. Heparin is also called antithrombin, and it affects factor 10 and 2, similar to warfarin, but also affects factor 12, 9, and 8. Okay, and of course thrombin. So heparin affects mostly the intrinsic pathway, and heparin can be tested by measuring APTT, and therefore APTT is a great measure of the intrinsic pathway. So heparin blocks factor 12, blocks factor 9, blocks factor 10, blocks thrombin, and also blocks factor 10 and factor 2. Okay. Lastly, tranexamic acid. Tranexamic acid is a drug that's given to patients in operations to prevent bleeding. It's also given to trauma patients who come in with hemorrhages and prevents them from losing a lot of blood by promoting clotting. And this works by preventing the conversion of plasminogen to plasmin, and therefore stabilizes the clot for a lot longer and prevents patients from losing a lot of blood. And I think that covers all of the information that you need in regards to the coagulation cascade for the MRCS. If there are any questions, pop them down in the comments box below, and I'll see you in the next one. Take care.